So today we are talking about low dose naltrexone, or LDN for short. Now, if you don't know what naltrexone is, it is a drug that was historically used to treat opioid abstinence, and it's also been used to treat alcohol abstinence, and in some cases you can actually use it in weight loss. But today we're talking about it in the context of the HRT and integrative medicine world. Well, you may be wondering, why would we even have a place, or why would it have a place in the HRT world? Well, the biggest reason that we use it, the biggest indication would be in Hashimoto's disease, which is one of the most common causes of thyroid disease, especially in the developed world. And if you think about it, the vast majority of cases of thyroid disease, hypothyroidism particularly, is caused by Hashimoto's. So if you know somebody that has Hashimoto's, chances are better check the siblings, better check the parents, better check the kids, because they probably have it. Anyway, so naltrexone, it is what's considered a pure opioid antagonist, meaning it purely binds and blocks the receptor. Nada. It sits on the place, occupies that receptor. Cool. Now, what utility does it have in the HRT world? Well, naltrexone, what happens is it'll upregulate it'll upregulate what's called opioid growth factor, or OGF for short. Now, how's it do it? Let's talk about it. So when you introduce naltrexone, what it does is it binds these OGF receptors. Well, if it binds the receptors, it displaces OGF that was previously on those receptors. Guess what? Those newly displaced OGF, they need a new home. Your body compensates by upregulating more receptors, and then they can bind that. So it creates this bind, displace, upregulate, bind, displace, upregulate, bind, this cyclical wash and repeat, rinse and repeat cycle. And what that does is it creates more OGF, it upregulates more OGF activity, and OGF is a very, very, very potent immunomodulator. On top of that, these cycles of bind, displace, repeat, also upregulates what's known as beta endorphins. And that also acts like an analgesic. It also helps immunomodulate as well. So through the process of increasing more OGF, more beta endorphins, you're really going to stimulate the immune system to be more active and provide more robust response. Now, when implementing naltrexone into an integrative practice or integrative program, we want to use the small compounded doses. Now, the branded drugs would be like Revia would be a brand version of it, and Vivitrol would be the injectable version for opioid abstinence. But what we use are the compound versions. We use the compounds, and they're usually somewhere in the ballpark of 0.5 milligram to 4 to 5 milligrams, and they come in little compound capsules. Now, the reason why we want to use small doses, not brand doses, such as like 50 milligrams, is because, again, if this is about the bind, displace, upregulate, bind, displace, upregulate. If you use those higher doses, what happens is you oversaturate, you hit the receptors, you saturate them, and then you don't get that displacement, bind, upregulate. You don't get that whole cycle. So we want to use the smaller doses so that we don't oversaturate the receptors, because with each of those bind, displace cycles, that's when you're really going to get more of an immunomodulatory response. When introducing LDN into someone's medication protocol, we typically advise they start taking it somewhere in the evening, late evening, and this is really going to augment that. The body's beta endorphin release response is what it's going to do. So you get a better response in that terms when you take it later in the evening. Now, the most common side effect people typically complain about is insomnia, and I always reassure patients that, it may suck for the first week or two, but just try to ride it out if you can, or just try to take it a little bit earlier in the day. But it's usually self-resolving within a few weeks. In terms of titration, you typically want to start off 0.5 milligram, 1 milligram, and then as you tolerate better, every few weeks you can titrate up by about 0.5 milligram or so. The goal is to eventually get to 4 to 5 milligrams and kind of just cruise there indefinitely. The biggest contraindication to taking this is, concurrent opioid therapy. So another thing to consider is if the patient is also on immunosuppressants such as like methotrexate or prednisone, those types of drugs can possibly reduce the effectiveness of LDN. Some considerations about the actual LDN you get compound itself Well, the first one is you should avoid extended release or sustained release versions of it. Again, the whole goal of low-dose naltrexone is to displace, bind, displace, upregulate, bind, displace, upregulate. Is to do that. If you have an extended release formulation, it's almost like having extensive binding of the receptors, and therefore you're not going to get that upregulation cycle. Another thing to consider is I've spoken to several compound pharmacists about this, and they recommend avoiding LDN that's compounded with calcium carbonate as a filler. So that's what a lot of the pharmacists have informed me. They say that calcium carbonate, if it's compounded with calcium carbonate as a filler, then that can interfere with the absorption. It can actually negate a lot of the absorption. However, they did say that sucrose is a fine filler, lactose, if you can tolerate it, is a fine filler as well, or cellulose. So if you're wondering what are some other conditions you can use LDN for, well, this is a great resource. This is one I've been using for the better part of a decade. It's ldnresearchtrust.org, and it displays a whole list, a whole conglomeration of different conditions you can use for it. The ones I particularly used for it was Lyme disease. Hashimoto's is on here, obviously. I've used it for Ehlers-Danlos, however the hell you pronounce that. Some other infectious conditions, infectious diseases you can use it in. Here's a big one, long COVID. Done that only a couple of times. But as you can see, there's a lot of different categories that you can use LDN in. Here's a whole list of different cancers and malignancies you can use to treat it with. But the big thing I see that it tends to get the most recognition for is in the realm of the autoimmune diseases. That's where LDN really does play a big role for a lot of clients. And this website's a wonderful resource. It talks about where you can find a provider directory. It lists all the different conditions. It even has a whole list of research and lots of studies to actually validate why you can use LDN. Well, that was a brief primer on LDN. Obviously, it wasn't super in-depth. I wanted to keep it a little more superficial, just so that if you are interested or you think this may be something that's beneficial to you, you have some resources and you have a little bit of knowledge to think about with it. Lastly, I like to tell people that this is an amazing drug. It's been around. They've been researching it at the low dose for almost what, 45, almost 50 years now, give or take. The big thing I always tell folks is it takes time. It really does. I mean, once you even get to your cruising dose, 4.5, 5 milligrams, I mean, you're going to be there indefinitely. I mean, 3, 6, 10 months before you start to get some appreciable benefit. So again, it's long and slow, play the long game, and hope you enjoy the video.